Good afternoon, everyone, and welcome. My name is Priscilla Bryce, and I am the CEO of the National Mental Health Consumer Alliance. I have the privilege of emceeing today's first webinar of our new series, Consumer-Led Conversations, hosted by the Alliance. I'll begin by acknowledging the traditional custodians of the many lands we are connecting from today. I pay my deepest respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. I also invite you to share which country you are zooming in from using the poll on your screen. This acknowledgement is not simply a formality. It is a recognition that sovereignty was never ceded. These always were and always will be Aboriginal and Torres Strait Islander lands. It is also a recognition that long before our mental health systems were built, First Nations people held systems of care, healing, and collective well-being. Systems grounded in kinship, in culture, in land, and in spirit. We are proud to honour our partnership with the Indigenous Australians Lived Experience Centre and the leadership of our First Nations board members. Their guidance ensures our work is not only informed by lived experience, but also by cultural authority and the principle of self-determination. I invite us all to hold in mind that true healing and justice in mental health must be built on truth-telling, cultural safety, and respect for Indigenous ways of knowing, being, and doing. Knowledge that has cared for this land for more than 65,000 years and has been passed down through the longest living culture in the world. So welcome everyone to the first consumer-led conversation supported by the Alliance. It is so wonderful to be joined by you all, and we are certain today's conversations will provide deep insights into the important work of lived experience leaders in the consumer movement, our community, and their proposals for structural change. We have a great program for you. Firstly, I will take you through the background of the Consumer-Led Conversations series, explaining how they were created and who we were presenting over the next 12 months. Then we will hear from our first two groups, the Multicultural Affinity Group, followed by the Psychosocial Affinity Group, sharing insights into major projects that they and their membership have been delivering. Finally, we will end with a Q&A, so please ensure that you place your questions into the Zoom Q&A function throughout the session. We will answer as many as we can. If anything goes wrong with the presentation, please also alert us using the Q&A chat function, and we will try and fix things as we go. So in June 2025, the Alliance Board decided that we needed to provide a space for our lived experience leaders to determine their own priorities and be supported to platform these priorities to a national audience. From this decision, Consumer-Led Conversations was born. This series is intended to create space for consumers to speak openly, critically, and independently. A space to elevate diverse consumer perspectives and enable reflective dialogue. While the Alliance provides the platform, the conversation belongs to our speakers. Each month, we will hear from lived experience leadership working in either location-based groups through our consumer advisory groups in each state and territory, or intersectionality and identity through our affinity groups. To explain this in more depth, each state and territory lived experience consumer peak body supports two self-determined lived experience leader groups. One is called a Consumer Advisory Group, or CAG, whose membership is based on location, though these groups may sometimes be called something different in your state or territory. The other groups are affinity groups, which are organised based on a common identity or intersectionality. And so the members of these groups may be based in a range of locations across the country. We have 9 affinity groups, including LGBTQIA+, neurodivergence, youth, older persons, forensic, regional and remote, governance of restrictive practices, along with psychosocial and multicultural, both of which are speaking today. You may wonder why there is no First Nations affinity group. We are proud to honour our partnership with the Indigenous Australian Lived Experience Centre and the leadership of our First Nations board members. Their guidance ensures our work is not only informed by lived experience, but also by cultural authority and the principle of self-determination. Each consumer advisory group and affinity group chooses its own methods to meet and work. However, every group has also been tasked with identifying a nationally relevant problem in mental health policy or service for which they determine a policy solution. The Alliance aims to integrate the findings and insights derived from these projects into our national advocacy framework and policy recommendations. Now, each group will also be presenting their ideas, projects, and policy proposals during our Consumer-Led Conversations webinars throughout the course of 2026, as well as additional insights into their work, membership, and expertise. Please also note that the views expressed are those of individual speakers and do not necessarily reflect the views or policy positions of the Alliance. Now it's time to get on with the show. So the Multicultural Affinity Group is supported by the Alliance, and we have 5 incredible speakers from the group joining us today, which you can read a bit more about on screen. Niharika Hymath will open the presentation. Niharika is the Alliance's Multicultural Affinity Group Chair and is a South Indian mental well-being peer practitioner and leader who advocates for addressing systemic gaps in the well-being, health, and multicultural communities and sectors. At the intersection of lived experience expertise and cultural responsiveness, she emphasises culture and identity's role in service delivery and systemic change and reform. Thank you so much for kicking off the presentation today, Niharika. Over to you.
Thank you so much, Priscilla. It is so lovely to be here, and thank you for that really lovely introduction as well. Folks, our topic today is going to focus on building shared understanding for and with multicultural mental health consumers. And as Priscilla mentioned, we'll be presenting on behalf of the Alliance's Multicultural Affinity Group. Now, Priscilla has given me a lovely introduction, and I would also like to extend those introductions to the other members of the group that are going to be presenting today. Today we have with us Nasima Mustafa from Queensland, Iman Mohammed from Victoria, Michael Elwan from WA, and Viviana Chan from New South Wales. We're hoping that these members and also the other members of the groups will be spoken about a little bit more in detail in coming weeks and months as we share a bit more about the stories and the journeys that we're bringing to this work. But yeah, I'm gonna pass over to Nasima to kick us off proper. Thank you, Nasima.
Thank you, Niharika. Sorry, I'm a little bit slow with the technology here. I'm very happy to be here, and I am really honoured to be part of this affinity group. The Multicultural Mental Health Affinity Group started in July 2025 by the National Mental Health Consumer Alliance. The Multicultural Mental Health Affinity Group exists to amplify the voices and experiences of multicultural mental health consumers and to inform how systems engage, design, and deliver mental health supports. Members from each state and territory are selected by the Alliance and by FECA, and Niharika introduced all of us earlier. The National Mental Health Consumer Alliance coordinates and supports the affinity group. Thank you. We'll move on to the next feature.
Over numerous meetings, our group has worked to identify key priorities and issues that impact mental health and well-being of multicultural consumers. These insights have been cultivated through in-depth and often deeply personal discussions about our collective experiences navigating mental health services and support systems as multicultural consumers. Our discussions explored a broad range of topics, including clinical and non-clinical approaches, the often subtle but impactful power dynamics that exist within mental health spaces, including experiences of tokenism, the role of language services, and culturally responsive practices, as well as the complexities of navigating structural and systemic challenges faced by multicultural consumers and families. Through these conversations, we also explored the use of lived experience engagement models, consumer-led leadership approaches, and the need for authentic co-production with diverse consumers with intersectional experiences. From this, we also examined best practice models, including those that exist within our own communities, such as grassroots services within multicultural communities and non-traditional approaches to care. Through our collective conversations about our lived experiences, we identified a range of key challenges and critical priorities to advocate for and examine through a policy and practice lens. These priorities will be called out, but also addressed during this session today.
Thanks, Iman. As Iman mentioned, as a groundwork for our approach, today we're looking to name 4 systemic problems that we've seen repeatedly come up across conversations with multicultural communities and across the lived experience sectors as well. In terms of the first of those challenges, it's around power and tokenism. Diverse lived experience input is often requested, but real power, resources, leadership roles, and governance doesn't really shift. And that tends to keep those dominant perspectives in control and allows racism and bias in different ways to continue harming consumers of mental health services. And secondly, in terms of language confusion, so terms like cold or culturally and linguistically diverse, multicultural, BIPOC or Black, Indigenous, or people of color, and calm or culturally and racially marginalized are often used inconsistently without sort of real understanding of what they mean. And without sort of shared rules and understandings, people are often mislabeled, excluded, or left without the language to describe what they're actually experiencing, especially when that cultural identity and mental health lived experience overlap as well. Thirdly, there is shortfalls around intersectionality and the way that it's acknowledged within the system. Culturally responsive services are hardest to find for people with multiple and overlapping identities. So folks, we're thinking disability, chronic illness, neurodivergence, LGBTIQA plus identities, asylum seeking or refugee folks, and housing insecurity, amongst others. And finally, often there is a clinical default, as we know with the broader mental health space. We continue to see increasingly clinical and medication first responses to things like grief and trauma and mental health challenges in multicultural communities, whilst those community-led and those non-clinical supports often sort of already doing the work to support the community continue to remain undervalued and underfunded. We define these issues through sector and community conversations, specifically centering multicultural lived experience and the impact on access, safe enough and authentic outcomes. And so for this phase of our work, what we're trying to do is prioritize these 4 areas with a strong emphasis on shifting power specifically. So in terms of the problem that we're looking to solve for the sector, mainstream organizations, services, and aligning sectors still rely on consultation with multicultural communities that is often tokenistic, inconsistent, and culturally unsafe due to a lack of that shared foundational understanding. And this is across multicultural lived experience and specifically the mental health sector as well. And so we're proposing a shared foundation and understanding to inform accessible resources and guidelines that help mainstream services move from that tokenistic consultation to meaningful engagement and shared leadership that's supported by clearer language, practical standards that it can inform, and pathways into things like governance for multicultural consumers and their communities. And to take you a bit deeper into what we're proposing, I will now throw to Michael.
Thank you very much, Niharika. So let me turn now to what we are proposing through this work. So at its core, we are proposing to develop a national policy document authored by this affinity group. It will be grounded in lived and living experience of multicultural mental health consumers from across all states and territories. The purpose of this document is simple but significant: to bring clarity, coherence, and depth to how the current mental health system is understood from a multicultural consumer perspective, and to lay a strong foundation for future reform. So, this work has three core components. First, we will synthesize our collective lived and living experience to surface shared patterns, priorities, and system level challenges. The intention here is not to tell individual stories, but to identify the deeper dynamics that shape people's experiences of things like access, safety, dignity, and care across different cultural, linguistic, and migration contexts. This allows us to move beyond isolated examples toward a clearer picture of how the system consistently works and fails for multicultural communities. Second, we will undertake a structured desktop review of existing policies, frameworks, and guidance. This enables us to understand what already exists, where there is coherence and where there is fragmentation, and where critical gaps or tensions remain. Importantly, this step anchors our work in the current policy landscape while allowing us to examine how formal frameworks translate or fail to translate as well into lived reality. And third, based on the synthesis of lived experience and policy review, we will develop recommendations for next steps in consultation and strategic alignment. So this will include national peaks such as FICA. This will ensure that what we are producing does not remain a standalone document, but can meaningfully inform future system guidance, advocacy, and reform efforts. However, it's very important to be clear about the scope. We are not attempting to produce a full set of national standards or operational guidelines within this time frame. Instead, we are deliberately focusing on producing a foundational policy contribution, one that creates shared understanding, coherence, and clarity about where the system currently stands and what must be addressed next. What does this work actually offer the broader system? At its core, it offers clarity and shared understanding. By bringing together lived experience and existing policies and frameworks, we are creating a clearer picture of how the mental health system is currently experienced by multicultural communities. Things like what is working, what is not, and where the most significant gap sits. For policymakers, this creates a stronger multicultural consumer-centered reference point to inform national policy and system guidance. It helps ensure that policy decisions are grounded in real-world experience rather than assumptions about access, equity, or inclusion. In practical terms, it supports better policy design by showing how policy settings actually play out in people's lives. For commissioners and funders, this work supports more informed decision making. It helps clarify what meaningful engagement, cultural safety, and accountability look like in practice, and how funding and commissioning choices shape access, trust, and outcome for multicultural communities. So rather than prescribing models, it strengthens the questions that funders and commissioners are able to ask when designing and evaluating services. And for organizations working with multicultural communities, this project offers a foundation for reflection, a foundation for learning and future development. It brings consumer experience and system analysis in a way that can inform organizational strategy, governance, workforce development, and service design, particularly in relation to cultural safety and engagement. And for clinicians and practitioners, this work provides deeper insight into how culture, migration, trauma, identity, structural barriers as well, shape mental health experience. It supports reflective practice and helps clinicians think more carefully about how people understand distress, help seeking as well, and healing. Across all this area, the deeper purpose of this work is to build shared understanding across the system so that future reform is more coherent and more accountable and more grounded in lived reality. In that sense, what we are producing is not immediate system change, but a strong foundation. It's one that helps the system see more clearly, think more carefully, and act more responsibly in relation to multicultural mental health. So what we have just spoken about is system level framing and how policies, funding, organizational practice, and the clinical care shape people's experiences. But none of that is abstract. It lives in very real moments, in very real lives, in very ordinary settings, classrooms, families, community, spaces, and everywhere else. So to bring this back to the human level, we now want to share a couple of grounded examples from the community. These are not success stories in the glossy sense. They are stories of how culturally responsive, relational, and respectful care can even change how people feel seen, heard, and supported, and how small moments of validation can carry profound mental health impacts. Bibiana will first share a story from the Community Flower Studio in New South Wales, followed by Nasima, who will reflect on her experience with culturally responsive mental health care through World Wellness groups in Queensland. And together, these stories bring to life what culturally responsive practice looks like when it is done well, and why the work we are proposing at the system level actually matters. So I'm going to hand over to Bibiana.
Hi, everyone. I'm Bibiana. I just want to share a story of McKay, a young member of the Community Flower Studio. Just a brief background, the Community Flower Studio is a youth-focused charity which we offer youth mentoring and we empower young people through creative arts. So this is McKay's story. She's a high school student. She told me she was once wanted to enter a poetry slam competition. Her poem was deeply personal. It was about the racial discrimination she had experienced. She titled it Model Minority. When she approached her teacher for guidance, the response she received was discouraging. She was told that if she was serious about the competition, she should change the topic. McKay felt frustrated, perhaps angry too. Instead of being supported, she felt unheard. So she wrote another poem, this time on climate action. When she shared this with me, I listened carefully. I acknowledged her feelings of invalidation, and I let her know that what she had experienced mattered. I encouraged her to send me her original poem, and I offered to publish it in the Community Flower Studio's e-newsletter whenever she felt ready. Months passed. I gently reminded her again, no pressure. Then after visiting ANU, I saw an art exhibition titled We Bleed the Same. I was deeply touched and took photos of several artworks. I thought of McKay and suggested maybe we share those images alongside her poem in a future newsletter. And then within a few days, she sent me a video of her poetry slam rehearsal. She asked me to share only the audio and not the video. I respected her request and published the audio in our December 2022 e-newsletter, accompanied by the exhibition images. When she read it, she said to me, "Baby, you edit the images and make it so cool." I share this story to highlight how unresolved discrimination and the invalidation of significant adults can have lasting impacts on a young person's mental well-being. At the Community Flower Studio, we strive to provide a culturally responsive and safe space where young voices are heard and respected. Today, McKay's audio is listed as a teaching resource with Together for Humanity. Her voice didn't disappear. It found a place to belong. Thank you.
Thank you. I'll start with my story as well. The organisation in Brisbane, World Wellness Group, have adopted the Mental Health Australia's Embrace Multicultural Mental Health Framework with their multicultural clients. I heard about this and I chose to engage two psychologists to support my children after their dad and I divorced. We were practicing Muslims, and having a therapist who understood our cultural and faith values was the priority to support them. My eldest son was adolescent at the time and struggling with many aspects of his life, including his faith, and this is what I would like to highlight. The therapist, as a strong practicing Christian, was able to support my son in the most beautiful way. Even when my son needed support with his faith, the therapist encouraged him to speak with an imam for guidance, which he did, and was peaceful after some time. Both my children have benefited immensely from the support they received as a result of culturally appropriate care. I'm extremely grateful that I was able to find an organization and therapists that could provide this sort of support for my children. It's made an immense difference. And it has also restored their faith in actually getting mental health support. Thank you.
Thank you so much, Nasima and Bibi and Michael and Iman. Those stories, as Michael rightly said, really sort of highlight the need for this work and the difference that it can make when you are able to access it. I guess in terms of our call to action today and how we want you to get involved. We want to hear your voices. We're really keen to work closely with multicultural communities across the country to develop this document, and especially those voices who are often excluded from these conversations. There's going to be a general survey, and we'll sort of speak to this toward the end of the webinar. And the recording of this particular piece is also going to go up on YouTube. But if there are pressing questions or thoughts that you have, please feel free to drop a line in that survey, and we can come back to you. Something to note, though, is that we are also looking and planning for sort of meaningful engagement and input from diverse communities, as I said, across the states and territories over the course of the development of the document. And so given that December is about the time that we're aiming for this to be developed, we'll hopefully be coming up with those more targeted sort of surveys and ways to be involved in coming months. And we are happy to answer any questions or initial thoughts that you have on the chat and in the Q&A later, and also really strongly encouraging folks to be involved with their state and territory peaks. We are keen to work closely with them to ensure that there's a broad range of multicultural voices that are represented within this work. And my mistake, no questions yet, just any initial thoughts. We'll loop back around for the Q&A. I'm on that note, I might pass back to you, Priscilla, and thank you so much.
Thanks, Niharika, and thank you to everyone from our Multicultural Affinity Group. We are really privileged at the Alliance to be hosting that group and organising the meetings, which means that we get a front row seat to hearing all the ideas that that group comes up with, and they are fantastic. So this national policy document that they're planning to finish, to complete and launch by the end of the year, I'm super excited about it because I really do think that policymakers will be interested in what's in it. So thank you, team, for the work that you're doing right now. Okay, should we go on to our next session? So our next group is the Psychosocial Affinity Group, supported by Mental Health Lived Experience Peak Queensland. Our speakers today are Jordan Frith and Simon Clow. Jordan, chair of this affinity group, is a lived experience representative and a psychosocial disability peer worker, actively involved in government systems to amplify consumer voices and centre diverse voices. Through advocating for improved system navigation and reduced harm in mental health, Jordan encourages consumers to play an active role in their healthcare. Simon is currently the Queensland Psychosocial Peak Body Coordinator and works at Mental Health Lived Experience Peak Queensland, who auspices this particular project. He is a passionate advocate for lived experience leadership and practice and continues to deepen his understanding of his own mental health, addiction, homelessness, and caring experiences. Simon believes that community and reciprocal relationships are essential to mental health and physical well-being. Over to you, Jordan and Simon.
Hi everyone. I'm Simon. I'll kick off for us today. Thank you so much, Priscilla. Appreciate the introduction. So the Psychosocial Affinity Group was something that sort of I think was really close to my heart. I've been obviously struggling with my own stuff for a long time, but also have worked in lived experience-led organizations for a long time, that some of which don't exist. And so for the last 2 years, I've been connecting with people in community and hearing their views. I'd really like to acknowledge the Yagara and Turrbal people on whose land we are here in Queensland. I'd like to honour the leadership of First Nations people, particularly in the last week or so. It's a rough time for mob. And I'd really like to acknowledge their generosity in sharing their knowledge that sustained their culture through deep time, and their connection in sustainable ways with country. And I'd like to acknowledge that sovereignty was never ceded, and that it will always be Aboriginal land. So what we're going to go through today, why we have a psychosocial affinity group. I think, the language is problematic. The word comes from a really good place, but it's maybe been through use with the National Split Insurance Scheme, something that not everyone doesn't sit really well for everyone, but is an incredibly important thing to be looking at in supporting our peers and community. We're going to look at how we've explored the problem so far as a group, and I guess sort of like what led to that, and how the ideas got us to the point that we're at. And then sort of how we've started to explore the solutions and what we might develop as a group that could be nationally influential and really bring community back into the mental health and wellbeing space. So looking forward, how we might as a group continue to develop something that's going to work and be influential in that space. So much about the previous presentation really resonated very deeply in what community really needs. I think it's that making sure that the group is able to shape something that can really inform future work. I think it's going to be a lot more work than what we'll just do as a group, but hopefully it will lead to some deep thinking and some changes. Just a little bit about Jordan and myself. I think we tend to lead with things about us rather than our professional backgrounds. But Jordan's an amazing advocate, and I've been lucky enough to work with Jordan in multiple situations over the years in community, and Jordan is the current chair of our Psychosocial Affinity Group and was the previous chair of the Mental Health Lived Experience Peak Psychosocial Special Interest Group, which this affinity group is kind of flowing on from. and I'll let Jordan, Jordan loves books and is an amateur florist and is just a generally amazing human, so reach out to them. I found a lot of recovery in martial arts and a blacksmith and yeah, sort of just do a bunch of things that bring me a lot of recovery and a lot of joy, and I guess that's probably impacted on the things that I feel and recognize as important for other people. So, currently working since the start of the financial year for the Mental Health Lived Experience Peak Queensland. I'd previously been lucky enough to work at a completely lived experience-led organization for about 9 years. So Malik is the Queensland peak body for consumers of mental health services, and seeks to ensure that the voice of lived experience is leveraging sort of our expertise in creating systems change and systems reform in order to improve that system for us and our peers and community, and ensuring that our human rights are respected and embedded. And yeah, that's a really big task. Luckily, to help us in that task, we have over 600 members that inform Malik's policy and practice. It was established in 2022, and we currently have 7 staff members-ish, like some of us are part-time. And so that's a bit about that. I think I'll pass over to Jordan. It's your turn.
Thanks, Simon. And yeah, so good to be with all of you today to talk about a really fantastic topic, and a huge thank you to the Multicultural Affinity Group. Just a little bit of scene setting, and Simon's described a little bit of this already, but the Consumer Peak in Queensland is a long-ish in lived experience terms, history with psychosocial engagement. We have the term here, psychosocial stuff. One of the things that we love about this topic is everyone has a really different and unique way of engaging with it. Some people prefer to use the term psychosocial disability. Some people prefer to use psychosocial need or psychosocial impairment, if that's their preference. But there's a lot of different ways that people engage with this topic. And so one of the key focuses for us is that we represent the uniqueness and the diversity around how people engage with it. So back in 2023, the Peak started looking at this topic in quite a bit of detail, prompted from the NDIS review and the major changes that were happening there, and then started operating the psychosocial peak body. The Psychosocial Affinity Group has a bit of a broader remit than kind of both of those peak based issues. So the composition of the group includes people who are NDIS participants for psychosocial disability, people who identify as having psychosocial disability but have had systemic barriers to accessing the NDIS, and then also people who don't use that terminology but still identify as a person who either benefits from psychosocial services or it just engages with that concept in a kind of a more comfortable way than they may with other kind of models of mental health. One of the things that's really come up around the diversity of the group itself is a lot of people who identify as neurodivergent or people who have kind of intersectional and marginalized experiences are more likely to engage with psychosocial disability and a psychosocial support concept than people who maybe fit a bit more comfortably into some more mainstream service solutions. So that's kind of how we got to where we are. We have a national remit. We're very early in the development phase, but much like the group before us, we've spent an awful lot of time trying to define the problem that we're looking to solve, or at least start to describe with this project. Overwhelmingly, the issue that we're seeing consistently from our community is that psychosocial supports are thin, and our community, lived experience communities, are often excluded from development of solutions. We see this in the NDIS space, but we also see this in terms of state and territory, public health systems trying to create psychosocial support services and systems without actually adequately involving lived experience communities in the development of those solutions. What that means is that we often get services that don't meet our needs, aren't considerate to either practical support or flexible support. They don't look at peer work in terms of their models. They use language or terminology that is not helpful or supportive of a psychosocial identity. And even within kind of the lived experience community itself, there's a lot of differences or understanding of psychosocial need and psychosocial disability broadly, and it can make it quite difficult sometimes to work towards collective advocacy on this topic, while also ensuring that we're respecting a wide variety of perspectives on it. So this problems are broad. So the solution or topic that we've landed on is connection is prevention. Yeah, this was a really big process that we went through with the Psychosocial Affinity Group. We had these really big, broad, abstract conversations, and then kind of narrowed in piece by piece at what we're actually looking at in terms of our projects. So what we identified is that we need alternatives to the NDIS and mainstream services, and we also need to be able to describe what those alternatives are so that we can see better outcomes for people both within the current system and completely outside of it, if that's where they kind of sit as a community. People with psychosocial disability or psychosocial need have are some of the most marginalized within our communities, and the need to have sufficient options available both within and outside of publicly funded systems is really, really important. We know that peer-led alternatives are good for our community, and we also know that connection is one of the fundamental mediators to both peer work and peer practice as a discipline, but also to our citizenship recovery and our individual recovery, or working towards well-being, whatever terminology people prefer. And we want supports that meet our needs and are driven by these values. This is a delight of a process to go through, and I really want to reaffirm we're in quite early stages in terms of the development and finalization of what we're working towards. But this is just a snapshot of what the group kind of co-developed. This was towards the ends of last year. We've had similar workshops since, where we have a collaborative process where everyone gets a chance to in a fairly unfiltered way, work towards defining the problem, defining solutions, using the language that makes the most sense for us. So we've spent a bit of time both investigating what the problem is, what these barriers are, but then also how connection actually functions within that broader system. This is a really high level kind of overview of what we identified. We've really identified, and this is consistent and well understood for everyone with a lived experience in our space, but discrimination has a profound effect on our well-being, and disconnection is a function of discrimination, or can be an output of discrimination. We found that connection is a mediating foundational factor for well-being. One of the things that came out quite strongly is that people don't necessarily feel that we recover or achieve a state of wellness on our own. We actually do that in relationship with our community, and we develop that kind of sense of wellness in collaboration and connection with other people. The other thing that we really agreed on is that mainstream models and clinical models in particular actively foster disconnection. They create isolationist or siloed approaches. This causes issues at a system level in terms of where services go and who actually gets access to them. But it also, kind of encourages a form of disconnection that is in and of itself quite harmful to our communities. We had quite diverse conversations as well about the term prevention. For those of you who kind of flit in and out of public health spaces, as I do, prevention's quite a medical term. So we had a robust conversation about why we're using it and how we're using it. And what we landed on is that prevention by itself is about preventing undue distress and adverse impacts for us as people and communities that would otherwise be avoided. But we're not looking to prevent difference or diversity. We actually really want to foster and promote people to grow and heal and become themselves in a lot of different ways. And so when we mean prevention, we mean the ways that the system harms us and not the way that we as individuals are different or divergent from that system. And we also really strongly agree that reciprocal relationships are key, and that's how peer work comes into it. Again, super early days in terms of where we're at. So we've mostly moved through this problem solution co-development phase. Where we're up to now is we're going to be doing a desktop review. We really want to make sure that we're not duplicating what's already been done. And then we're going to come back together as a full group and develop a shared criteria for deciding on what policy solution or mechanism would be appropriate to produce out of this work. We will also be looking at kind of developing a lived experience model of connection so that we can really clearly describe what we want out of kind of these alternatives that we're describing. It will also be most likely, again, not to put the cart before the horse, but we'll be likely producing a report that has a series of recommendations for government or other decision makers within the system that points to where current systems are failing or causing harm or disconnection through the way that they're operating, and what alternatives can look like within our current landscape or future landscape. Throughout this whole process, we'll also be continuously checking in with our community. So we have the core group, which is the affinity group, but we also have broader networks of people who are connected in around this topic. And we really want to make sure that we're testing our assumptions over and over again so that what we create is reflective of what our community is saying on this topic. And I might just throw back to Simon for a last comment.
Again, thanks so much for that, Jordan. Yeah, I think please get in touch with us. Like, we're really interested in hearing from absolutely anyone that has experiences or advice or interest in this space. We're contactable at sort of engagement at Malik, and I'm always available to have conversations with people who have experienced stuff in community, and I'm constantly doing that through the work that I'm currently doing in coordinating that psychosocial peak body. I've been lucky enough to connect with a whole bunch of groups in regional areas this year in Queensland, but was lucky enough to meet with some people from Western Australia recently who also have like an NDIS focused group. And it's really in coming together as people with lived experience and refining that expertise that we're going to find the creative solutions to help problem solve in this space and hopefully guide us in a new direction that will allow people to kind of avoid some of those harms that are present in the system and some of the problematic ways that that system is performing currently. But yeah, I'd like to thank everyone so much for their time. I'd really like to thank the National Mental Health Consumer Alliance for making this work possible. And I'd love to thank the other group for all of the confirmation bias that was in their incredible presentation. It's really like together these solutions work sort of collectively for everyone, and we should be listening more than we're speaking frequently in this space so that we can find the knowledge to find a better way forwards together. So yeah, thank you for your time.
Thanks, Simon, and thank you, Jordan, as well. I really like this affinity groups project too, and especially the slide that you had with all your sticky notes. It looks like you've gone through a really creative process, and it sounds really inclusive. So I think this project will be fantastic. Really looking forward to seeing where you go with it. In particular, the connection is prevention. That really rings true to me too. So we're going to transition to our panel discussion now and our Q&A. So please remember to put your questions into the Q&A function on Zoom. And we will answer as many as we can before we conclude at around 6 p.m. Australian Daylight Time. So we have about 7 minutes left. Given that the multicultural group finished first, I'm going to throw a question to them because they've already had a little bit of time to think about how they might answer some questions. So get Niharika up.
Hello.
Uh, Hi, Niharika. So we have a question for you. What are the challenges or barriers to implement culturally responsive community-led programs?
Just that little question, Priscilla. No, look, thank you. Thank you for the question. Thank you for firstly naming that there is challenges and barriers to this work. We're hoping that we can capture sort of this in more depth in our work. Some of the sort of key barriers that kind of jump out for me are specifically around the sort of meaningful acknowledgement of intersectionality and how that's sort of addressed within the current way that the system holds culturally responsive work. It's very much sort of focused on putting people in baskets and trying to have a clear idea of what their identity and their one identity is, right? As a person of color, as a person from this multicultural background, or as a queer person. And so really thinking critically about how some of those sort of challenges arise around meaningfully addressing multiple parts of someone's identity and recognizing they kind of interact and interflow with each other. I think the other piece, as we know in the current sort of climate with lived experience work more broadly, it's slowly sort of moving out of that place of being the shiny new thing. And I'm really conscious that, already being in a sector and a space, whether that's mental health, whether that's lived experience, where those multicultural voices are not heard and held in a meaningful way, as we sort of then transition into this sort of plateau space of work. How do we sort of ensure that we have a collective representation of a broad range of voices and views of multicultural communities from sort of across the sector? And the last thing that I will sort of speak to specifically talks to the community-led aspect, and a lot of it really comes down to the funding piece, right? We are very happy to fund we're very happy to fund clinical approaches and things, and how do we sort of start to rework some of those funding models in a way where we can actually prioritize the needs of communities and let them prioritize, right? Give them the agency to prioritize those more.
Thank you, Niharika. And I'm glad you raised funding. Can we get Simon and Jordan to turn your videos on too? I do have a question for one or both of you, whoever wants to answer it. And it is around funding. We all know that psychosocial funds are really difficult to get. Do you think your project will help with that?
Look, I'm certainly hoping so. I really, yeah, sort of over the last sort of 12, 13 years, the situation has changed quite drastically in what's available for people in community to access. We've swung from what was a very social model of disabling experiences into one that's become highly medicalized. We know that there's at least, I think the data is saying about 700,000, but I think those of us that have worked in this space for a while know that that would be, possibly up to sort of 900,000 or more Australians, and certainly over 195,000 Queenslanders who desperately need psychosocial supports, who cannot access those. Unfortunately, NDIS supports are for people that can afford them currently. The estimate is that it costs you at least, $1,500 to access the NDIS and prove your eligibility. And that wasn't always the case. There used to be places in community that you could get practical support to mitigate some of the harms of struggling with your mental distress. You could turn up to a place and get some housing support if your housing was falling apart. You could turn up to a community center and connect with some people around some meaningful activity to give you an identity outside of illness to help putting your life back together. And none of that exists anymore. Unfortunately, we've kind of gone to this individualized, sort of very measured to the point of incredible restriction kind of a process. And although some of that still hangs on in places, it's I think led to some of the intense distress and some of this mental health crisis that we're seeing currently. So I really hope, and I know that the federal and state government actually need to come to some kind of agreement about funding the foundational supports and psychosocial supports. And I think health departments and disability departments across the country are concerned about this and do realize that, for every day that someone's in hospital, that's somewhere between, I mean, obviously the distress and harm and the trauma and the, having to rebuild your life is important, but that's also $1,500 to $3,000 of taxpayers' money. It's not being well spent and it's causing people harm. We could look at different solutions and allow community who knows what they need to recover to lead that recovery. And I really hope that what we're doing together leads to at least some dent in that in some way, shape, or form. Jordan, do you want to jump in on that?
Just extremely quickly, I think one of the things that we're identifying is a lot of, at this extremely early stage, is that a lot of the solutions and supports that people want are very cheap, and even beginning to describe what those are and making that economic argument is something that we aren't really interested in doing. But the other thing we're really interested in doing is creating something we can give to people in community to support them to advocate for their unique needs, because that uniqueness is extremely important and powerful to recognize. So yeah, just really a lot of potential. We're not going to make too many promises right now, but
Thank you, both of you. That was great answers to that question. So thank you. Unfortunately, it is time to wrap it up now. So we'll just finish off by letting you know that the next consumer-led conversation is scheduled for Tuesday, the 24th of February from 5 p.m. Australian Eastern Daylight Savings Time. Please be sure to join us to hear from the Affinity Group, which is convened by Mental Health Lived Experience Tasmania, who will be looking at governance model of restrictive practices, as well as the Regional and Remote Affinity Group, which is convened by Consumers of Mental Health Western Australia, looking at the provision of advocacy services for consumers living in regional and remote areas who are placed under involuntary orders. We ask that you complete the evaluation form that will appear on the screen when the webinar ends, and we will also email you the form later today. As this is the first of the Consumer-Led Conversations series, your feedback is vital to making these conversations a success. Finally, a recording of today's conversation will be available on our website, which is nmhca.org.au. And for those of you who are mental health consumers, I encourage you to join your local peak body if you have not already. Details of each peak body are also on our website. To hear about future consumer-led conversations, please sign up to the Alliance's mailing list, which is also available on the website, or follow us on social media. Thank you to all our panelists for their time today and to all who joined us for this event. Bye for now.